Of course, there are many challenges and unmet needs in multiple myeloma, really throughout the whole spectrum. Even in the earliest stages, we're trying to determine should we screen or not for myeloma. At the level of smoldering myeloma, when do we initiate treatment and do we do so in full or in part? At actual induction therapy, what is the best induction therapy? Is it a triplet? Now it looks like it's a quadruplet. And if so, do we go to transplant? Do we not go to transplant? Do we perhaps replace transplant with CAR T cell therapy? And then, of course, perhaps the greatest unmet need still remains in the relapse setting, because despite all of these great advancements early on, patients still relapse with this disease. Patients still have multiple relapses typically, and so we've not cured myeloma yet. And so what is the best sequence and what is the best therapy for patients with heavily relapsed multiple myeloma still remains a challenge. I think one of the greatest advances that we're seeing in multiple myeloma right now is the move from triplets to quadruplets. And interestingly, we're seeing it both in patients who are eligible for transplant and for those that are not eligible for transplant. And conceptually, it makes sense that we introduce more mechanisms of action, and that way we gain more control of the disease, especially as many of these drugs do not have overlapping toxicity, or if they do, we've become better at managing them, dosing appropriately, and that's, I think, one of the keys to doing this correctly, is dosing them appropriately where we can get the benefits of multiple mechanisms of action, but without the over-treatment, as it were, or the overlapping toxicity. And so we've now seen with the ASCIA trial adding isatuximab to carfilzomib, lenalidomide, and dexamethasone, in the Perseus trial adding daratumumab to bortezomib, lenalidomide, and dexamethasone, and even in transplant ineligible patients in the IMRAS study adding isatuximab to the standard of bortezomib, lenalidomide, and dexamethasone. We've seen that these quadruplets are feasible, that they demonstrate superiority over the triplets with respect to efficacy, and indeed are manageable in their toxicities. Yeah, we've now had the results of BOSTON and STOMP for several years, and we've now been really introducing them into practice. And I think this is a particularly important point, because very often important studies like BOSTON and STOMP are completed, but then as we translate them into the clinic, we want to give the best opportunity to our patients to have response and to maintain that response. And one of the massive shifts we've seen with selinexor is moving from higher dose twice weekly therapy now to lower dose once weekly, that the drug is very effective at 60 milligrams once weekly. And the significance of these studies is that now we've learned that we can partner selinexor with literally all other myeloma therapy. So I very routinely use it with proteasome inhibitors like bortezomib and carfilzomib, with immunomodulatory drugs like lenalidomide and pomalidomide, and indeed now with monoclonal antibodies with daratumumab or isatuximab. And so it now really serves as a fourth class, in addition to proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies, as an option to be combined to obtain, as we were saying, the best response by virtue of multiple mechanisms of action, while maintaining a tolerable regimen, which toxicities we're becoming much better at managing with the once weekly dosing, with the proper use of antiemetics and supportive care. Yeah, we've really seen a remarkable move of daratumumab to the front line. Of course, as most drugs in myeloma, it has to prove itself in the heavily relapsed setting, then move into the early relapse setting, and then move into the frontline setting. And now it really is become the standard of care in frontline myeloma to use an anti-CD38 antibody like daratumumab. We've been using it for quite a while already in transplant ineligible patients with daratumumab, lenalidomide, and dexamethasone-based based on the Maya trial, but also been using it now with these new quadruplets, as we saw in the Perseus study with daratumumab, bortezomib, lenalidomide, and dexamethasone. And so we've noted that in each of these situations where we add daratumumab to a previous standard of care, we deepen response, we make it more durable, and although there is always some increased toxicity, it's typically manageable as we care for our patients with frontline myeloma. As we look to the future of myeloma, I think there are several things that are likely going to be key steps in providing patients deeper, more durable responses with better quantity and quality of life. I'm not speaking yet on the verge of a cure because I still think there's time for us to get there. But as we move towards a cure, we make a disease more chronic, we make it more manageable in the long run. And I think key goes through an evolution as we learn more about it and how to apply it. And so that has happened to a great degree with proteasome inhibitors, with immunomodulatory drugs, and monoclonal antibodies. We've just gone through that evolution with XPO1 inhibitors. And now looking over these next few years, we are optimizing the use of CAR T-cell therapy and bispecifics, let alone all the new CAR Ts and bispecifics that are coming. And that transition from clinical trial to real world practice, which is something that we're really now focused on, and I believe is really important, because it's one thing to prove something in a clinical trial, it's another thing to be able to deliver it in practice as we pragmatically use these drugs in the clinic. And for example, dosing of bispecific antibodies. Many of these doses that initially started weekly, we've realized that we don't really have to give it weekly indefinitely. We can drop it down to every other week or every third week or even every month, and that's better for patients. We've been able to move many of these therapies from primarily an inpatient setting to an outpatient setting. So I think part of our overcoming those challenges is going to be the pragmatic use of these drugs. And then secondly, overcoming challenges always has to do with great research and science. And so as we understand the disease better and determine, should we be screening for myeloma? What other targets can we find on the myeloma cell? What other molecules can we use? We've been focused so much on CAR Ts and bispecifics, and that's great, and even trispecifics, but we do want simple, easily taken molecules, oral agents that are also going to help patients, especially those who are older and more frail. So it's really exciting to see where we've come, but also I think even more exciting to think about where we can go in myeloma over the next several years.